It is a pleasure to be presenting at the 12th edition World Congress on Nursing Education and Practice. My name is Dr. Alicia Jones, and I'm an advanced practice nurse educator and researcher at the University Health Network and Toronto Metropolitan University in Toronto, Canada. Today, I will be presenting my doctoral research study, which focused on examining collaborative practice between two main categories of frontline nurses working in various acute care settings. This research was carried out at one of the major hospitals in Toronto, Canada. Now, as I am doing this via virtual platform, in person, I would have asked for a show of hand for all nurses in the room. Then I would start by categorizing by saying BRNs, those are RPNs. In the States, they would say LPNs, and in other parts of the world, it might be tailored to different names. And these are usually nurses who have done less years of studies um, uh, other than the years designated for for RNs, however, are still called nurses under the umbrella of nurses who are in practice. Now, you may wonder why this study. After working with the main two groups of frontline nurses as an educator, a manager, and a researcher, I had the chance to observe the way in which they worked as a team and the benefit as well as the barriers that existed. This sparked my interest where I wanted to understand their lived experience about what collaborative practice means to them, hence this study. The hospital organization where the research was conducted is located in downtown Toronto. It is inclusive of three acute care sites, one long term care, three rehabilitation unit, and an educational institution. The hospital is a major employer of nurses in Ontario, as 4,565 nurses work across the network, accounting for 32% of the total employees. Over the past 6 years, a practice design called the Nursing Skill Mix Model was introduced to specialized acute care units, which were referred to as SAC units. Examples of these units are cardiology, transplant, thoracic, neurology, nephrology, medical, surgical, and emergency rooms. The nursing skill mix model was identified as an important staff element that involved the mixing of nursing staff, primarily registered nurses that are referred to as RNs and registered practical nurses who are referred to as RPNs. While it is typical for RNs and RPNs in our long term care and rehab settings to operate within a nursing skill mix model, this work structure was introduced to SAC units in the response to hospital increasing nursing shortage due to a reduction of global recruitment and the COVID pandemic, necessitating a shift in care provision by the standards set out by our legislative body called the College of Nurses of Ontario. Since the implementation of the nursing skill mix model on SAC units, no formal review has been conducted to assess the effectiveness, hence the reason for completing this research study. The purpose of this research was to identify barriers that break down collaborative practice and establish strategies that could be used to strengthen teamwork and collaboration between RNs and RPNs on SAC units. The proposed problem of practice concerns the historical isolation and compartmentalized approach to nursing care between RNs and RPNs, and the impact that it has had on their collaborative practice. Two main purposes of the nursing skill mix model were to one, bridge the gap of silo practice, and two, to increase nursing staffing. However, over the years, there have been an increase in barriers to collaborative practice with poor outcomes, one of which is RPNs having less desire to work on SAC units where some have resigned their positions. 3 research questions were coined, 2 for phase 1 and 1 for phase 2. Phase 1 looked at examining how was collaboration practiced on SAC units and what were the enablers and restrictive factors, while Phase 2 examined how can RNs, RPNs, and nursing leadership staff co-create together to develop strategies that could be used to strengthen collaborative practice between both groups of nurses on SAC units. The research design used in phase 1 was semi-structured interviews and in phase 2 was semi-structured focus group discussions. The research methodology used in the study is action research, which is pioneered by Kurt Lewin and other psychologists in 1950s. This methodology uses a process of gathering the evidence to implement change in practice, which is generally participatory and collaborative in nature, which enable the researcher and stakeholders to refine their approach based on ongoing feedback and evaluation. 2 theoretical frameworks were used to support the study. The first is convergent theory, which was developed in the 1960s by a psychologist by the name of Clark Kerr, who looked at how we can intentionally devise actions that promote a more integrated and collaborative approach to healthcare delivery, aiming to improve patients' outcome, enhance the quality of care, and promote overall well-being. The second is a theory developed by Ludwig von Bertalanffy, a psychologist in the 1940s, where the approach to health is employed in a scientific way to comprehend factors affecting health outcomes. It clarifies the relationship among these factors and adapt designs, processes, or policies based on acquired knowledge to improve health outcomes. Participants, stakeholders, and collaborators, they all played integral part in the research process. Without them, pretty much your study do not go on. And what they do, they guide your study through consultation, involvement, collaboration, and empowerment, ensuring that diverse perspectives are considered and valued. In phase 1, a total of 8 RNs and 8 RPNs participated in semi-structured interviews, and stakeholders who supported the study were the Chief Nursing Executive, the Director of Education, the Director of Professional Practice, and the Clinical Research Manager, who in a collaborative way assisted with proposal application, ongoing meetings, and presentation, which were used to sensitize both senior leadership staff and some RN participants about the study. The participants in phase 1 worked on 5 specialty areas. These were thoracic, cardiology, emergency room, nursing resource team, and general internal medicine. Their years of experience ranged from 0 to 3 years to 8 to 11 years, and there were 11 females and 5 male participants. In phase 2, there were a total of 13 participants, of which 2 were RNs, 2 were RPNs, and 9 were nursing leadership staff. The nursing leadership group comprised of 1 nurse coordinator, 2 advanced practice nurse educator, 2 patient care coordinators, and 3 nurse managers. The years of experience ranged from 0 to 5 to 26 to 30 years. All participants practice on either surgical, medical, or outpatient services and shared in semi-structured focus group. There were 9 females and 4 male participants. Phase 1 findings were achieved through semi-structured interviews carried out virtually via Microsoft Teams. In vivo and descriptive coding was the method used to analyze the field notes that were gathered, and the core themes that came out were a lack of knowledge, inferiority, frustration, and lack of job satisfaction. Of the 16 participants, 94% did not fully understand theirs or each other's scope of practice, where RPNs felt like they worked outside their scope. 80% RPNs felt inferior and less than a nurse, where junior and senior RNs saw RPNs as incompetent and did not exhibit much enthusiasm to work alongside them. 87.5% RPNs experienced verbal hostility and humiliation, where RNs would call them half nurses, as becoming an RPN requires 2 years of study when compared to RNs who would study for 4 years. 75% felt rejected and unwelcome to SAC units when RNs fail to identify them as nurses. This makes them feel like they wanted to quit. From the findings in Phase 1, Phase 2 action steps were developed. This was mobilized in the form of focus group discussions that were intentionally designed to have frontline RNs and RPNs have separate sessions from nursing leadership staff. This was geared towards creating an environment where nurses would feel comfortable to express their lived experience without fear. The concept was to have them co-create together by openly sharing what strategies they deemed would be beneficial to use to strengthen collaborative practice between RNs and RPNs based on the findings from Phase 1. 5 focus group discussions were held, of which 3 were with nursing leadership staff and 2 were with RNs and RPNs, which occurred on February 8th, February 10th, February 12th, February 13th, and February 15th. Utilizing in vivo and descriptive coding, data were analyzed where 5 core themes were identified. Of the 13 participants, 100 agreed that scope of practice needed to be clarified to prevent role ambiguity. 100% agreed that organizational leadership needs to play a direct role to enact strategies to strengthen collaborative practice between RNs and RPNs. 100% agreed that team and capacity building is significant to strengthen collaborative practice on SAC units, and 100% agreed that education on respect and civility is important for positive collaboration between RNs and RPNs. Anonymous quotes were shared by participants about the various themes that were derived from the analyzed data, including the need for role clarity, the need for hospital organization to drive campaigns over several months in order to develop better collaborative work culture between RNs and RPNs, to initiate team building practices at the beginning of the shift, to get rid of silo practices by making RPNs become included in educational and departmental activities, and the use of empathy to appreciate each nurse as a person who brings value to nursing practice and respecting their choice to become an RN or an RPN. Job and career satisfaction were expressed by participants to be the primary focus to prevent losing our nurses. When this does not exist, RNs and RPNs experience a lack of job satisfaction, and it has direct impact on role confusion and cause RPNs to feel less than a nurse and unwelcome to the team. Developing relationship practice through storytelling and art-based therapy was seen as a strategy to build capacity to show the value of each person, their profession, and expertise, which is important to strengthen collaborative practice. The historical silo in nursing practice has led to some of the barriers experienced by RPNs on SAC units. Silo practice between RNs and RPNs have accounted for medical errors and even death. Isolated practice between both groups of nurses have led to nursing shortages and an unhappy work environment. Dismantling segregation in the workplace would enhance teamwork between RNs and RPNs. Successful change happens when there is an understanding of why the change is needed and the outcome that will be derived from it. Strategies that are not evidence based in practice often fail to meet goals and objectives, whereas practice guided by evidence based practice forms patterns that are intuitive and goal oriented, whereby strengthening collaborative practice. From the findings of the research, 5 pillars were identified for consideration and future research. Consideration should include reflection. This should ask questions like, where are we? How did we get here? And what future state do we desire? Further movement should be centered on increasing activities that should drive intentional actions to support collaborative practice through education. The importance of organizational leadership taking the lead from a top down approach is significant to ensure that everyone is included in the change. Concurrently, organizational leadership is in that position of influence to provide resources to strengthen and maintain collaborative practice on SAC units. And it is essential that the findings from the study is disseminated in ways that can effect changes to strengthen collaborative practice between RNs and RPNs, to foster job satisfaction, improve work environment, and continued research. In summary, collaborative practice between RNs and RPNs is essential for holistic organizational care, interprofessional collaboration, tailored precision care, and fostering self care for both patients and health providers. It is significant that RNs and RPNs are aware of the importance of working with each other and not over each other as they both work towards common goals. As healthcare practitioners, we are stronger together. According to Henry Ford, coming together is the beginning, keeping together is progress, but working together is success. Thank you for listening to my presentation. References are available upon request. I would love to take your questions.